Hello students, in this session we will talk about nerve injuries in upper limb.
Clinical significance related to brachial plexus are Erb's Duchenne paralysis, Klumpke's paralysis, brachial plexus block, and winging of scapula. So let us start with Erb's Duchenne paralysis. Before that, let us talk about a very important anatomical point, which is Erb's point. Now, in the illustration on the right side, you can see this is the site which is called as Erb's point. Erb's point is located on the side of the neck 2 to 3 centimeters above the clavicle and in front of the transverse process of sixth cervical vertebrae. Any pressure over this point may elicit the condition called as Duchenne-Erb's paralysis, or even with electrical stimulation of this area may cause the muscles of the arm to contract. Erb's point, it is the confluence of six nerves, that is, six nerves meet here. They are C5 root of the brachial plexus, C6 root of the brachial plexus, nerve to subclavius, suprascapular nerve, anterior and posterior division of superior trunk of the brachial plexus. So, any compression over this area may result in compression of these six nerves, which may result into symptoms likewise. Now let us start with Erb's Duchenne paralysis, may simply be called as Erb's paralysis. This condition arises because of the compression or injury to upper trunk of the brachial plexus. Now we know that upper trunk of the brachial plexus has the root value C5 and C6, and hence C5 and the C6 roots are injured in this condition. Now what may be the etiopathogenesis behind this condition, Erb's paralysis? Any injury or any condition which results in hyperextension of the neck, that is, any condition which result in excessive increase in the angle between neck and the shoulder, may result in tear of the nerve fibers present in the C5 and C6 roots. Now let us try to understand this by seeing the illustration. On the screen you can see the neck, the increase in the angle between the shoulder and the neck has occurred. As a result, the upper trunk of the brachial plexus comes at the risk and the nerve fibers may get stretched or even teared. Now, when can this occur? This may occur during childbirth while performing the lateral flexion of the neck. Excessive lateral flexion may result in Erb's paralysis, or it may occur during fall from the height, as fall from the motorcycle or fall during horse riding, which are commonly seen condition. As a result, you can see the excessive increase in the angle between the shoulder and neck is occurring. This may also result because of the heavy backpacks. Again, the same compression of the upper trunk occurs in these all conditions. Now, whenever hyperextension of the neck occurs, that is, increase in the angle between neck and the shoulder occurs. Now we need to remember which all are the nerves which are affected. The nerves which are affected in this condition, Erb's Duchenne paralysis, are musculocutaneous nerve, axillary nerve, nerve to subclavius, and suprascapular nerve. And the muscles which get paralyzed are bicep brachii, brachialis, coracobrachialis. These three muscles are paralyzed because they are innervated by musculocutaneous nerve. Now, the muscles which are innervated by axillary nerve which get paralyzed in this condition, Erb's Duchenne paralysis, are deltoid and teres minor. Now, nerve to subclavius, it innervates subclavius muscle which get paralyzed. Suprascapular nerve innervates supraspinatus and infraspinatus. So total 8 muscles get paralyzed and 4 nerves are affected in the condition called as Erb's Duchenne paralysis. Now we need to understand what are the clinical features with which patient presents. Because of the paralysis of the muscles, the patient is unable to perform abduction at shoulder joint. As a result, his upper limb remains by the side of the body in adducted position. He is unable to perform lateral rotation of the arm, that is lateral rotation at shoulder joint, and hence the upper limb is in medially rotated position. He is unable to perform supination of the forearm, and hence upper limb is in prone position. And he is unable to perform flexion at elbow joint. As a result, the elbow joint remain extended, and this characteristic position is called as waiter's tip deformity or policeman tip deformity. Apart from the motor loss, patient also complain of sensory loss over the area involving the area supplied by the axillary nerve and the musculocutaneous nerve, which are over the upper part of the lateral surface of the arm and over the lateral surface of the forearm. The next clinical condition related to brachial plexus is Klumpke's paralysis. This is the condition which arises because of the injury to lower trunk of the brachial plexus. We know that lower trunk of the brachial plexus has the root value C8 and T1. Students, C8 and T1 spinal nerve are responsible for innervation of the muscles and the skin over the hand, and hence all the clinical features which you will see in Klumpke's paralysis will be related to deformity or the sensory loss over the hand. Now let us see the details of Klumpke's paralysis. Klumpke's paralysis occurs whenever the condition resulting in hyperabduction at the shoulder joint occurs. As a result, stretching of the lower trunk of the brachial plexus and even tearing of the nerve fibers present in the lower plexus may occur. Now let us see when this can occur. Imagine a condition in which person falling from the height catch hold of something which comes on the way in order to protect himself from falling. In this condition, hyperabduction at the shoulder joint may occur, which may result in tearing of the nerve fibers present in the lower trunk of the brachial plexus. And we know that lower trunk of brachial plexus has the root value C8 and T1. Now, the illustration on the right side of the screen shows the other condition in which lower trunk of the brachial plexus may be affected is during childbirth. As you can see, the doctor is trying to bring out the child by pulling the hand. As a result, in this condition also hyperabduction may occur and injury to the lower trunk of the brachial plexus may occur, as you can see here. Now let us try to understand what all are the signs and the symptoms with which patient will present to us. In this condition, because of the injury to C8 and T1 spinal nerve, the short muscles of the hand will get paralyzed. As a result, the patient will present with a clinical condition called as ulnar claw hand. In this, the extension at metacarpophalangeal joint and flexion at middle and distal interphalangeal joint will occur in case of digits 4th and the 5th digit. Patient will also present with Horner syndrome. Sensory loss over the medial 2.5 and according to few literature, medial 1.5 part of the hand and medial side of the forearm and arm will be there. Horner syndrome. Horner syndrome is the condition in which triad of ptosis, meiosis and anhidrosis occurs along with loss of ciliospinal reflex and enophthalmos. Next condition is winging of scapula. As we have already talked about winging of scapula in previous 2 sessions, so we will quickly see the condition. Winging of scapula occurs because of the injury to long thoracic nerve, which has the root value C5, C6 and C7. This nerve is also called as nerve of Bell. Long thoracic nerve provide motor nerve supply to serratus anterior muscle. So this muscle will get paralyzed. Serratus anterior is responsible for protraction of scapula and it also helps in overhead abduction, and hence patient with paralysis of serratus anterior will have difficulty in protraction of scapula, that is performing pushing and punching movement, and he will have disability in performing overhead abduction. Whenever he tries to does pushing and punching movement, at that time medial border becomes prominent, and hence the condition is called as winging of scapula.
Brachial plexus block. This technique involves injection of the anesthetic drug in the axillary sheath in order to desensitize the nerves which form the brachial plexus. It can be done by three approaches: interscalene approach, supraclavicular and axillary route. As you can see in the illustration here, this represents the interscalene approach, this being the supraclavicular and this being the axillary route approach. We know that roots of the brachial plexus, they come out from deep to superficial plane by passing in between scalene anterior and scalene medius muscle, and while doing so they pull a layer of deep fascia along with them, which is the extension of prevertebral layer of deep cervical fascia, which later on in the axilla will be called as axillary sheath. So this concept is utilized to give the anesthetic drug through interscalene approach. In this condition, as you can see in the illustration here, the patient is asked to sniff because scalene anterior and medius are the accessory muscle of respiration. During the sniffing maneuver, the patient makes the two muscles prominent in order to make the groove between them prominent, which is then utilized to inject the anesthetic drug around the nerves forming the brachial plexus. Supraclavicular approach. This is based on the principle that the trunk of the root and the trunk of the brachial plexus are present in the posterior triangle. Here, the site of injection, as you can see in the illustration here, the site of injection of anesthetic drug is approximately 2 cm above the mid-clavicular point. The needle is inserted backward, inward and downward in order to anesthetize the nerves forming the brachial plexus. The last approach is the axillary approach, where the anesthetic drug is injected inside the axillary sheath in the proximity to the axillary artery. Now let us start with individual nerves. We will briefly revise their course and then learn about the cause and effects of the injury to the nerves. We will start with median nerve first. Median nerve, which has the root value C5, C6, C7, C8 and T1, is also called as laborer's nerve. Median nerve in the arm does not give any motor branch. However, it gives vasomotor branch to the brachial artery and its branches. In the forearm, median nerve provides motor nerve supply to all the muscles of the flexor compartment except flexor carpi ulnaris and medial half of flexor digitorum profundus. Along with these motor branches, median nerve in the forearm also gives a sensory branch, which is palmar cutaneous branch, which provides sensory fibers to the lateral 2.5 part of the palm. After entering into the hand by passing deep to flexor retinaculum, that is in the carpal tunnel, median nerve divides into it gives a recurrent branch which provides motor nerve supply to the thenar muscles, abductor pollicis brevis, opponens pollicis, and superficial head of flexor pollicis brevis. Then the nerve divides into two terminal divisions, or the ramus, which are medial and lateral ramus. These ramus provide motor nerve fibers to first and second lumbrical and then provide cutaneous nerve supply to the digits. Median nerve in the hand is responsible to provide cutaneous fibers to the lateral 3.5 digit and lateral 2/3 part of the palm. The territory of the median nerve extends dorsally till the distal and proximal phalanx of the same digits. Median nerve also provide articular branches as well as vascular branches. Median nerve is prone to get injured at the level of elbow, as seen in cases with supracondylar fracture and pronator syndrome. It is also prone to get injured at the level just above the flexor retinaculum, which is the most common site of median nerve injury, as seen in cases with the stab wound. Median nerve is also prone to injury at the level of the wrist joint, as seen in cases with carpal tunnel syndrome. We will first learn about the most important clinical condition which is responsible to give rise to median nerve injury or median nerve compression. The condition is called as carpal tunnel syndrome. The etiological factors responsible for this condition may be anterior dislocation of the lunate bone, tenosynovitis of the tendons of the flexor muscles, which pass deep to flexor retinaculum, conditions which give rise to fluid retention in the body like hypothyroidism, pregnancy, hypoproteinemia, etc., and obesity. Whenever a nerve gets compressed, patient may come with three types of symptoms. They may be motor loss, sensory loss, or autonomic symptoms. Autonomic symptoms include vasomotor changes and trophic changes. The case with carpal tunnel syndrome will come with a motor loss which involves paralysis of the thenar muscle except deep head of flexor digitorum brevis and adductor pollicis, because these two muscles get their nerve supply from ulnar nerve. First and the second lumbricals will also be paralyzed in the case with carpal tunnel syndrome. The case will come with a characteristic deformity of the hand which is referred to as ape thumb deformity, in which, because of the paralysis of the thenar muscles, flattening of the thenar eminence will be seen. About the sensory loss, the patient will have paresthesia, hyposthesia, or anesthesia depending upon the degree of nerve compression. The patient will have these symptoms over the palmar aspect of lateral 3.5 digit and dorsal surface of the same digits extending till the distal and the proximal phalanx except the thumb, where the paresthesia will extend only till the distal phalanx. Please note, the palmar cutaneous branch of the median nerve is spared in cases with carpal tunnel syndrome, and hence the sensation over the lateral two-third part of the palm will be spared. The patient will come with vasomotor changes like the skin will be dry, warmer, and trophic changes like drying of the skin, nail cracking, and atrophy of the finger pulse will occur. This illustration is to show you how ape thumb deformity looks like. On the left side is the normal palm, and on the right side you can see, because of the paralysis of the thenar muscle, thenar eminence is flattened. So this is how ape thumb deformity looks like. When the median nerve is injured at the level of the elbow, then all the symptoms which we saw during median nerve injury at the level of wrist, that is in carpal tunnel syndrome, all those symptoms will be there, and additionally patient will have following symptoms. This patient will have paralysis of all the long flexor muscles except flexor carpi ulnaris and medial half of flexor digitorum profundus. The patient will come with following presentation. The forearm of this patient will be in supination. Patient will complain of weakness during flexion of wrist joint, and flexion of wrist joint is yet possible because the flexor carpi ulnaris and medial half of flexor digitorum profundus is yet intact. Whenever the person tries to perform flexion at wrist joint, then automatically adduction of the wrist occur because of the pull exerted by flexor carpi ulnaris and medial half of flexor digitorum profundus. The patient will also complain of inability to perform flexion at proximal interphalangeal joint of all the 4 digits and failure to perform flexion at distal interphalangeal joint of 2nd and 3rd digit. However, the flexion at distal interphalangeal joint of 4th and 5th digit is yet intact because flexor digitorum profundus, which goes to the 4th and 5th digit, that is medial half of flexor digitorum profundus, is yet functional. Patient is also able to perform flexion at metacarpophalangeal joint because of the lumbricals and interossei. With this background, let us now learn about the characteristic clinical presentation of the patient with median nerve injury. When the median nerve is injured at the level of the elbow, then the patient will have this presentation, which is called as hand of benediction or Benedict's hand. Now, what are we seeing here? The patient with median nerve injury, when he is asked to make a fist, at that time, the patient is not able to flex the proximal and the distal interphalangeal joint of 2nd and 3rd digit. because of the paralysis of flexor digitorum superficialis and flexor digitorum profundus. And hence, when this patient is asked to make a fist, at that time, the index and the middle finger lag behind. However, he is able to perform flexion at 4th and the 5th digit. So the patient will have presentation like this. Another deformity is eighth thumb deformity, in which flattening of the thenar eminence occurs. The next characteristic presentation of the patient with median nerve injury in the middle of the arm is called as pointing index. As we can see, the index finger is pointing in this case. Now, when does this occur? Whenever median nerve is injured in the middle of the forearm. In this case, the branch of the median nerve which provide nerve supply to the fibers which are going into the fibers of flexor digitorum superficialis which enter into the index fingers. These fibers are involved. However, the fibers which goes to the 3rd, 4th and 5th digit are spared because they get their nerve supply in the proximal part of the forearm. And hence, because only the flexor digitorum superficialis which goes to the index finger, those fibers are paralyzed, and hence when the patient is asked to make a fist, at that time only index finger lag behind, other fingers are able to flex at interphalangeal joint, and hence patient comes with the presentation called as pointing index. Patient with a median nerve injury at the level of the elbow or middle of the forearm will have sensory loss involving the lateral 3.5 digit and lateral 2/3 part of the palm, and the sensory loss extend over the dorsum of the hand involving the corresponding digits over the distal and the proximal phalanx. This patient will also present with the vasomotor and the trophic changes. The illustration on the screen shows the area supplied by the median nerve which will have sensory loss. Now let us learn about certain tests which are used to detect the integrity of the median nerve. First is pen test. We know that median nerve supplies abductor pollicis brevis, which is responsible to bring about thumb in abducted position. Abduction of the thumb means the thumb is brought at 90 degree to the plane of the palm, as you can see in the illustration here. In the pen test, the patient is asked to touch the tip of the pen, and in order to touch the tip of the pen, the patient will have to perform abduction. That is, he has to bring the longitudinal axis of the thumb perpendicular to the plane of the palm. And if he is able to do so, this means median nerve is intact and hence abductor pollicis brevis is intact. And if he fails to perform this act, this means that median nerve is injured. The next test which can be performed to check the integrity of the median nerve is by testing the power of opponent's pollicis muscle. In this test, the patient is asked to perform opposition against resistance. As you can see, this is the hand of the patient and this is the hand of the examiner or the doctor, and the patient is asked to perform opposition against the resistance offered by the examiner. The next test by which the integrity of the median nerve can be tested is by checking the power present in flexor pollicis longus, which is also innervated by median nerve. In this case, the doctor holds the proximal phalanx of the thumb of the patient and then asks the patient to perform flexion at the interphalangeal joint in case of first digit, that is thumb. If he is able to perform flexion at interphalangeal joint, this means that median nerve is intact and flexor pollicis longus is yet functional. The next test is called as Ochsner's clasping test. In this, the patient is asked to clasp the hand. The index finger of the affected side fails to do so, that is, fails to flex at interphalangeal joint, and this indicates that median nerve is injured at the level of middle of the forearm. Now we will see the details of ulnar nerve injury. Ulnar nerve, which is the branch of medial cord of brachial plexus, has the root value C8 T1. It is also called as musician nerve. Ulnar nerve does not give any branch in the arm. In the forearm, it gives motor fibers or the motor nerve supply to two muscles, flexor carpi ulnaris and medial half of flexor digitorum profundus. In the lower part of the forearm, ulnar nerve gives two cutaneous branches. One is palmar cutaneous branch and other one is dorsal cutaneous branch. The palmar and the dorsal cutaneous branch are responsible to provide cutaneous nerve supply to the palmar and dorsal side of the medial one-third part of the hand. When the ulnar nerve enters the hand by passing superficial to the flexor retinaculum, it divides into its two terminal branches, superficial and deep. The deep branch of the ulnar nerve is responsible to provide motor nerve supply to all the intrinsic muscles of the hand except the deep head of flexor pollicis brevis, adductor pollicis, first and the second lumbrical, whereas the superficial part or the superficial division of the ulnar nerve, it is responsible to provide motor nerve supply to palmaris brevis, and then it becomes cutaneous and provides cutaneous nerve supply to the medial 1.5 digits. Ulnar nerve is prone to get injured at the level of elbow joint where it passes through cubital tunnel, and at the level of wrist joint it is prone to get injured when it passes through Guyon's canal. Injury to ulnar nerve. The patient may present with a motor loss due to paralysis of flexor carpi ulnaris, medial half of flexor digitorum profundus, third and the fourth lumbrical, all the dorsal and the palmar interossei, hypothenar muscles, palmaris brevis, adductor pollicis and deep head of flexor digitorum brevis. And the sensory symptoms with which the patient with ulnar nerve paralysis is that the patient complain of paresthesia or anesthesia over the medial 1.5 part of the hand on the dorsal and the palmar side. Patient with the ulnar nerve injury comes with a characteristic presentation of hand which is called as claw hand, in which flexion at interphalangeal joint of fourth and the fifth digit occurs and extension at metacarpophalangeal joint occurs. This occurs because of the unopposed action of extensor digitorum. Lower the ulnar nerve lesion, more pronounced is the clawing, and this is called as ulnar paradox. The patient with ulnar nerve injury complains of weakness of flexion at wrist joint, and whenever the person performs the flexion at wrist joint, then automatically abduction of the wrist or abduction at wrist joint occurs because of the pull exerted by flexor carpi radialis. How can we test clawing of hand in cases with ulnar nerve injury? Clawing can be tested by asking the patient to extend the fingers, and when he does so, he is unable to bring about extension at interphalangeal joint of fourth and the fifth digit. However, extension at metacarpophalangeal joint occurs. Now, why is it so? Or what is the anatomical basis of having clawing of hand in cases with ulnar nerve injury? Students, normally, extension of the digits is brought about by contraction of extensor digitorum. This extensor digitorum is a powerful extensor of metacarpophalangeal joint, but it has to act along with lumbricals and interossei in order to bring about extension at interphalangeal joint. And how does this extensor digitorum bring about extension along with interossei and lumbricals? All these three set of muscles, they act on dorsal digital expansion in order to bring about extension at interphalangeal joint. Now, when a patient comes with ulnar nerve injury, this patient will have paralysis of lumbricals and interossei, and hence complete extension of interphalangeal joint could not be brought about. So, this extensor digitorum will contract more and more in order to compensate the action of lumbricals and interossei. But extensor digitorum won't be able to bring about complete extension at interphalangeal joint. Rather, because of the excessive contraction of extensor digitorum, hyperextension will occur at metacarpophalangeal joint. So, this is the anatomical basis of clawing of the hand in the cases with ulnar nerve injury. The second site where the ulnar nerve can be injured is at the level of the wrist joint. At the level of the wrist joint, ulnar nerve can be injured when it passes deep to volar carpal ligament, or we may say when the ulnar nerve passes through Guyon's canal. These cases in which ulnar nerve paralysis occur at the level of the wrist joint, these cases will also present with ulnar claw hand. However, clawing will be more pronounced in these cases, and this is known as ulnar paradox, which means that lower the ulnar nerve injury, greater is the amount of, or the greater is the extent of clawing of the hand. Now, students, if we go back and revise the meaning of claw hand, then we may say that clawing of the hand means hyperextension at metacarpophalangeal joint and flexion at interphalangeal joint. When the ulnar nerve is paralyzed at the level of the wrist, in these cases, the nerve supply to flexor digitorum profundus remains intact, and hence, because of the contraction of flexor digitorum profundus, which brings about flexion at distal interphalangeal joint. So in these cases, along with the hyperextension at metacarpophalangeal joint, active flexion at distal interphalangeal joint will be there, and hence the characteristic hand, that is ulnar claw hand, will be more pronounced. Also, the cases in which the injury to ulnar nerve is at the level of wrist, in these cases, cutaneous innervation over the dorsum of the hand is preserved. The ulnar claw hand must be differentiated from Waxman ischemic contracture and from Dupuytren's contracture. Now, the test which can be used to check the integrity of ulnar nerve is called as Froment test. In this, the subject is asked to hold a book with the help of a thumb and index finger. Normally, when ulnar nerve is intact, in this condition, the subject will hold the book with the use of adductor pollicis and first palmar interossei. But in cases with ulnar nerve injury, because of the paralysis of adductor pollicis and first palmar interossei, the subject won't be able to adduct the thumb towards the palm, and hence he uses his flexor pollicis longus muscle and flexes the thumb in order to hold the book. As you can see in the illustration on the left side, the arrow with the P represents the abnormal side and the other thumb is the normal side. The modified form of Froment test is the card test, in which instead of using a book, we can use a card and ask the patient to hold the card with the help of the thumb. In order to hold the card, the subject will use the palmar interossei and will adduct the thumb and will try to hold the card. If the subject holds the card, then the power of the muscle can be tested by pulling the card, and this is how the integrity of the ulnar nerve can be tested. Next branch of the brachial plexus is radial nerve. Radial nerve, it is the branch of posterior cord of the brachial plexus. It is the largest branch of the brachial plexus. It has the root value C5, C6, C7, C8 and T1. Radial nerve in the axilla gives motor nerve supply to long head of the tricep along with the medial head of the tricep. And it gives one sensory branch, which is posterior cutaneous nerve of the arm. Then it enters into the spiral roof where it provides motor nerve fibers to medial and the lateral head of the tricep. The branch which goes to the lateral head of the tricep is long. After providing fibers to the lateral head of the tricep, this branch of the radial nerve proceed ahead and provide motor nerve fibers to anconeus and articular fibers to elbow joint. Then, in the spiral roof, radial nerve gives other two cutaneous branch, one of which is lower lateral cutaneous nerve of arm and the second one is posterior cutaneous nerve of forearm. In the lower part of the arm, after the radial nerve comes out of the spiral roof, it gives motor nerve fibers to brachialis, brachioradialis and extensor carpi radialis longus. And then at the level of lateral epicondyle, radial nerve divides into its terminal branches, which are superficial and deep branch. The deep branch, which is called as posterior interosseous nerve, will provide motor nerve supply to the extensor muscles of the forearm, whereas the superficial branch will descend downward deep to brachioradialis and will enter into the hand, where it gives dorsal digital branches to the lateral 3.5 digits. Radial nerve may be injured either in axilla or in spiral groove or in lower part of the arm. In the axilla, most commonly radial nerve is injured because of the wrongly fitted crutches, and the condition is called as crutch paralysis. In the spiral groove, radial nerve may be injured secondary to fracture of the shaft of humerus or in the condition called as Saturday night palsy. In the lower part of the arm, radial nerve, when it crosses the lateral intermuscular septa, there the radial nerve is tethered because of the branches, motor fibers of the radial nerve, which goes into the brachialis and brachioradialis. Because of these branches, the radial nerve is fixed, and hence it is prone to get injured in the lower part of the arm. This represents how the wrongly fitted crutch apply pressure on the radial nerve in the axilla. This represents how the back of the chair may apply pressure on the radial nerve when it traverses spiral groove. When the radial nerve is injured in the axilla, then the patient will come with the clinical features of inability to extend the elbow joint because of the complete paralysis of the tricep muscle. Patient will come with wrist drop, that is inability to extend at wrist joint, and inability to extend metacarpophalangeal and interphalangeal joint. The patient with the radial nerve injury in the axilla will have sensory loss over the dorsum of the hand involving lateral 3.5 digit and lateral 2/3 part of the dorsum of the hand, except the skin over the distal and the middle phalanx. The cutaneous sensation will be preserved there. The patient will also have vasomotor and trophic changes over the skin. When the radial nerve is injured in the spiral groove, in this condition, extension at elbow joint is preserved because when the radial nerve reaches the spiral groove, it has already given branch to long and the medial head of the tricep, and hence weak extension at elbow joint is yet possible in cases with radial nerve injury in spiral groove. The other features will be same as that previously discussed. The patient will have wrist drop, the patient will have inability to extend metacarpophalangeal and interphalangeal joint. The sensory and the vasomotor changes will be same. Injury to posterior interosseous nerve will result in wrist drop. However, the nerve supply to anconeus, supinator and extensor carpi radialis longus will be preserved. There won't be any sensory loss because posterior interosseous nerve is purely motor nerve. Injury to the superficial branch of the radial nerve will result in sensory loss over the lateral 2/3 part of the palm and lateral 3.5 digit, except the skin covering the distal and the middle phalanx. There won't be any motor loss because superficial branch of the radial nerve is purely sensory. Musculocutaneous nerve injury. Musculocutaneous nerve, which has the root value C5, C6 and C7, is the branch of lateral cord of the brachial plexus. Injury to musculocutaneous nerve is rare. Whenever occur, it results in paralysis of bicep brachii, coracobrachialis and brachialis muscle. This will result in weakness in flexion and supination of forearm. Flexion is also brought about by brachioradialis and the muscles of the flexor compartment of the forearm, and hence weakness of the flexion at elbow joint will be seen. Injury to the axillary nerve. Axillary nerve, which is the branch of posterior cord of the brachial plexus, which has the root value C5 and C6. This axillary nerve, it passes inferior to the head of the humerus, and then it winds round the posterior surface of the surgical neck of the humerus, where it is accompanied by posterior circumflex humeral vessels. It divides into two terminal branches which are anterior and posterior division. The anterior division of the axillary nerve provides motor nerve supply to the anterior fibers of the deltoid, and the posterior division provides nerve supply to the remaining fibers of the deltoid and to the teres minor. The branch of the axillary nerve which provides motor nerve supply to teres minor has pseudoganglion in it. Now, what are the conditions in which injury to axillary nerve may occur? The injury to axillary nerve may occur in cases with inferior dislocation of the shoulder joint, in cases with fracture surgical neck of the humerus, or in cases with incorrect use of crutches, which is rare but yet possible, and in cases with faulty technique used to give intramuscular injection in deltoid region. Cases with axillary nerve injury, they present with the flattening of the round contour of the shoulder due to atrophy of deltoid muscle, and they complain of loss of sensation over the lateral side of proximal part of the arm over the area called as regimen batch area. Cases with axillary nerve injury complains of loss of abduction beyond 15° at shoulder joint. They also complain of weakness of flexion and extension at elbow joint. Injury to thoracodorsal nerve. Thoracodorsal nerve, which is the branch of medial cord of the brachial plexus. It descends over the inferior part of the posterior border of the axilla. This nerve to latissimus dorsi, also called as thoracodorsal nerve, it is prone to get injured in the surgeries involving the posterior wall of the axilla and during mastectomy while removing the axillary tail of Spencer. The patient or the subject with thoracodorsal nerve injury are unable to raise the trunk with the upper limb as is done during climbing, and they are not able to use properly the axillary crutches. With this, we end up this session. Thank you.